Anshul from the Bayer Medical team. Firstly, I'd like to welcome you all and thank you all for taking out your time from the busy schedules for this Bayer sponsored eyesight meeting. Today, we have two speakers, Dr. Aditi Gupta, who is a VR consultant at Sunetra Super Specialty Eye Care Center, Ghaziabad, and Dr. Vidhi Bajpayee, who is a VR consultant at Nirmal Ashram Eye Institute, Rishikesh. The session will be moderated by Dr. Saurabh Arora, who is Senior VR Surgeon at Shreya Eye Center. And the topics of the two talk will be first, Dr. Aditi Gupta will be speaking on strategies for maximizing treatment durability, treat and extend approach with aflibercept, followed by Dr. Vidhi Bajpayee speaking on aflibercept in diabetic macular edema, primary treatment or secondary option. So now I'll welcome Dr. Saurabh Arora, who will be moderating the session. Over to you, sir.
Thank you, Manshu, and welcome you all for this Bayer Eyesight meeting. Well, I think we all know one of the most common things to happen in our clinics is, to see the patients is DME or probably the AMD, and we see frequently. So I think we'll just get some insights regarding the same from Dr. Aditi and Dr. Vidhi. So we'll start with this session. I think we can do the question answers later, maybe after the two talks. So first, Dr. Aditi will be speaking about strategies for maximizing treatment durability, the treat and extend approach with aflibercept. Dr. Aditi, are you there?
Yeah. Hello, sir. Good evening.
Hi, good evening. Good evening. So please welcome. Yeah.
Yeah. I'll just start sharing my screen.
Yeah. I'll just read about till the time. I'll just read about the objectives what we have for this particular meeting. I think we basically will explore the unique molecular features of anti-VEGF agents with focus on aflibercept efficacy and establish durability of aflibercept utilizing treat and extend regimen in wet AMD. And well, we'll have our clinical experiences regarding the use of aflibercept in various cases of wet AMD, and targeting pathways lead to which improvement in the efficacy in wet AMD. Accordingly, we can have a discussion. So yeah, please, Dr. Aditi, are you ready?
Yeah, I'm ready.
Yeah, sure.
Good evening, everybody. Today I'll be speaking on strategies for maximizing treatment durability, the treat and extend approach with aflibercept. So we know that neovascular AMD is a long-term disease that requires consistent treatment to maintain the patient's visual outcome. And we have also seen that the resumed treatment, when the lesion reactivates, leads to a visual loss of around 3.3 letters and sometimes more. So we need to advocate the continuation of anti-VEGF therapy even in our stable patients, because the estimated proportion of eyes with lesion reactivation in year 1 in studies is around 41% and in year 5 was around 79%. So the variation in VEGF suppression time, it varies from patient to patient, and hence we need to tailor the treatment according to the patient. We need to personalize the treatment. And the mean duration of VEGF suppression by aflibercept is to be seen between 10 weeks to up to 16 weeks in our patients. So when wet AMD, when the treatment, how it has evolved treatment-wise. So when the Marina and the Anchor study came up, there was fixed monthly treatment. While the Marina study, it established that the standard treatment of choice is anti-VEGFs for wet AMD, while Anchor proved that how it was almost better, if not inferior, to PDT. But this led to the overwhelming management burden in the standard of care, which led us to the peer study, where after 3 monthly injections, patients were given quarterly injections, but then this treatment was inadequate and the efficacy was compromised. This led to what we call as the PRN pro rata regime, which a lot of us follow for some patients. But again, this was causing a lot of monthly management burden to the patient, financial constraints were there. So we need to do a proactive treatment for the disease. So proactive treatment is a tailored treatment where can be fixed dosing, where regular injections are given, and there is treat and extend, which we'll be discussing now. So here the treatment interval is adjusted for each individual according to the visual acuity or the anatomic response to the treatment or the duration of the VEGF suppression. There's also treat to target, where regular injections are given until the disease stabilizes, but then monitoring is required, retreatment is required, and a lot of patients don't turn up because of the financial issues. So initially, the traditional treat and extend regimens only allowed interval extension up to the 12th week, but again, this was with high injection burden to the patients. So we needed to figure out something where the anti-VEGF treatment burden was minimized along with the patient's vision not being compromised because of it, which led to the principle of TN treatment and extend, which we follow now, where every visit is a treatment visit for the patient. So the pragmatic treat and extend approach with aflibercept, it allows optimization of the visual outcomes in a patient, also with a reduced burden, which we are aiming for. So the main studies, the first studies which were done for this were the ALTAIR and the ARIES studies, which assess the treatment intervals for up to 16 weeks post the treatment. So in the ARIES studies, in both the ARIES and the ALTAIR studies, treatment naive patients were taken, where they were injected at weeks 0, 4, 8, and 16, and then they were randomized. In the ARIES study, there were early start treat and extend and late start treat and extend, where the early start ones were given injections adjusted 2 weekly after the initial 3 monthly injections, and the late start one, it was started a year after. This interval was started a year after the monthly injections. In the Altair study, again, similar thing was done, and 2 weeks and 4 weeks adjustment was done. And it was seen that at week 52, which extended up to week 96, the visual acuity of the patients were maintained. So in the ARIES study, there were 23% patients which required an 8-week interval between patients 6 to 16 and under week 104, but the majority of these extended beyond week 8 by up to week 104. In the Altair study, we saw that the proportion of patients extended to week 16 intervals at the final visit, which was the week 96, in both the 2-week interval adjustment and the 4-week interval adjustment. In Altair study, up to 96.2% of the patient extended up to week 16, maintained this to the interval of week 96 with aflibercept. And again, this was comparable in both the groups which we had taken, which is the 2-week interval group as well as the 4-week interval group. So this led us to the roadmap that week 16 durability of aflibercept is there. Now, the treat and extend regimen is an individualized treatment, like we said. So we decide according to the fluid present. So there can be either if there's no fluid present, and if there's no loss of the letters or the CRT, there's no increase in the CRT, there's no neovascularization, there's no macular hemorrhage, the treatment is extended. If the fluid is decreasing and the other criteria remain the same, we maintain the treatment. While if we see a presence of any new fluid, we shorten the treatment. So the minimum treatment interval is kept at 8 weeks, and the maximum can extend up to 16 weeks. So when we're comparing the disease activity in the fluid compartments, what we have observed is that the worst kind of fluid is generally the intraretinal fluid, which is associated with poor visual outcomes at the baseline and throughout the course of the treatment. While the best kind of fluid is the subretinal fluid in the absence of intraretinal fluid, because again, it is generally associated with good visual outcomes of the baseline and throughout the course of the treatment. The role of the sub-RPE fluid again depends on the presence of IRF. If IRF is present, then the visual outcome is not great. And if SRF is present along with sub-RPE, generally there is good visual outcome in the patients. In around 47 to 60% of the patient treated with aflibercept, they reached the interval of 12 weeks and beyond in the various clinical trials which were done. There was also a comparison with the Hawke and Harrier trial, which we are not considering here. And if we compare the real world patients of wet AMD, the outcomes are comparable to those with RCTs, which are done with aflibercept. The level 1 data has shown that fewer aflibercept injections are required versus ranibizumab to maintain the vision gains. In fact, the injection at the end of the year 2, the number of injections was still lesser, and it led to minimized treatment burden for the patient with the same resources, and hence more patients responded to the treatment. In a network analysis, the level 1 data showed that fewer aflibercept injections were required versus ranibizumab to maintain vision gains, and when we considered the treat and extend approach, then they were even more favorable as compared to the PRN approach. I have a few case scenarios here of my own patients. So this is a 64-year-old male who presented with diminution vision in both the eyes. The BCVA was 6, 12, and 10. On clinically examining the patient, there was some RP changes at the fovea, and also there was a small macular hemorrhage. This is the right eye OCT. You can see there's PEDs, there's ellipsoid zone disruption, and there's some minimal RPE fluid. The same patient in the left eye, again, there was some exudative material, there was disruption of the ellipsoid zone. So I injected both the eyes of the patient with aflibercept. This is after dose 1, 4 weeks later, where you can see that the right eye, there's more SRF seen here, and the left eye, again, more SRF seen. The patient went with the second dose. After the second dose, the SRF decreased. PD is still there. But after the third dose, that is 12 weeks later, the vision improved to 6/9, and the left eye, we can see that the PED is almost resolved. There's no SRF, there's minimal scarring, and the right eye still has some SRF. I've advised more injection to the patient and waiting for the results. This is a second patient, a 69-year-old female who presented with diminution of vision in her left eye since a week. The best corrected visual acuity was still 6, 6, and 6, but she was insisting that left eye she could not see clearly. Clinically, there were RP pigmentary changes at fovea, no submacular hemorrhage, nothing of that sort. This is the right eye OCT, where you can see that there are multiple drusen's with some subfoveal disruption, and also there's minimal scarring subfoveal. But she was still maintaining her vision at 6, 6 in this eye. This is the left eye. This showed SRF, PEDs, and we can see that this is clearly a CNVM case. So in the left eye, I advised her aflibercept injection. She received the first dose. This is at after the first dose, 4 weeks post the first dose, where you can see that the SRF is resolving. The visual acuity was stable, and she was given the second dose. This is 4 weeks after the second dose, where SRF is very minimal and PD is also decreasing. Third dose was given. In between this, she started complaining of metamorphopsia in the right eye. When I saw her clinically, there was a small macular hemorrhage there. So I advised her aflibercept for this eye as well. She took the injection. After 8 weeks, I saw that the right eye was stable, but then again there was reactivation in the left eye. So the fourth dose of aflibercept was given in the left eye. This is the OCT of the right eye and the left eye at week 24. She's maintaining 6/6 vision. This is at week 28 with stable vision. And I'm waiting for her for the follow-up later on. This is the third patient, around an 80-year-old male, who presented with diminution of vision in the left eye since a month. Right eye BCVA was 6/6, left eye was 6/60. Clinically, there was a very, very small changes, but I could see a very small macular hemorrhage in the left eye. This is the left eye OCT of the patient. I advise aflibercept in this patient. After 4 weeks, the vision in the left eye improved from 660 to 624. PED is resolving. I gave the second monthly dose to the patient. This is after 8 weeks, where the visual acuity further improved to 618. PED is almost similar, slightly decreased. The third dose was given to the patient. This is at 12 weeks, where the visual acuity has improved to 612 and the PED is further flattened. So this is at 20 weeks, where the OCT picture looks pretty similar, but the vision was stable at 612. Patient was happy. After 24 weeks, the patient again started complaining of diminution of vision in the left eye. Vision dropped to 618 from 612. And I gave the fourth dose to the patient in the left eye. This is at follow-up after 32 weeks, where the left eye 612 vision is maintained, vision was stable, patient was happy. This is follow-up OCT at 40 weeks, where vision was maintained. This is follow-up after 56 weeks, patient was stable, maintaining the vision. At 68 weeks, the left eye vision was being maintained, but the patient came up with diminution of vision in the right eye. I clinically saw a large PED. This is the OCT of the right eye. I promptly advised him aflibercept injection because I didn't want to take a chance. That was the better eye initially. And at 72 weeks, this is the left eye still stable. Patient is maintaining 612 vision, and the second dose for the right eye is planned for the patient. So the take-home message is that anti-VEGF treatments are associated with high clinical and patient burden, which reduces the long-term compliance of the patient because of the increased healthcare costs. So if the intervals between treatments are too short, patients have a risk of being overtreated, leading to unnecessary treatment burden and sometimes minimal adverse effects, which we see. And if the treatment intervals are too long, then patients may be undertreated, leading to potential inferior functional and anatomic outcomes, also eventually scarring. So the goal of anti-VEGF treatment for us, for exudative AMD, is to improve and maintain the functional and the anatomic gains over and beyond the first year of treatment, along with minimizing the treatment burden on the patients, so that the patients can have at least stable vision for as long as possible. Thank you.
Yeah, thank you, Dr. Aditi, for a wonderful presentation and sharing your beautiful cases also. I think we can have a question answer later. So we'll start
Yes,
with the second presentation by Dr. Vidhi Bajpai regarding aflibercept and DME, primary treatment or secondary option. Are you ready, Dr. Vidhi? Dr. Vidhi, you are not audible. Dr. Vidhi, you are not audible. Okay, there is a message from Dr. Vidhi. I think she's just told to hold on. Mr. Manshu, are you there?
Yes, sir, I can hear you.
I think she has some issues connecting.
Yes, sir. So meanwhile, sir, we can take a question or two.
Yeah, I
from
think
you
by the
guys.
time she joins, I think we can take question with Dr. Aditi.
Yes.
Yeah, Dr. Aditi, are you there?
Yes, sir.
Okay, Dr. Aditi, but just like I would like to know like an important part. I was just looking at your cases, the
Yeah.
clinical cases. How far are you like, into doing an ICG now? And do you still do ICG for these kind of patients?
So I would love to do ICT, but we don't have it at a
You don't
center.
have it. Yeah, I can
I
understand that.
have sent one or two patients to eye care actually.
Okay. Because you have those cases, no, they are
Yes,
wonderful cases, but then
yes.
a lot of them, if you note, right, they have some tall PEDs and multiple tall PEDs, which actually can
Could be
be
PCV, yeah.
exactly. So you may be dealing with something else, but yeah, I can understand that limitation is always there, when we don't have ICG and okay, but what is your first choice of treatment? Like, in case you have a treatment knife, what exactly are you looking forward for?
So if there is especially a PD like what we saw in the last case,
Mm-hmm.
my first choice is always Eylea only because
Okay.
the chances of rip is as seen is quite less. So
Mm-hmm.
that's my first choice.
Okay.
Uh, Second choice in patients is Pagenex.
Okay.
But I've like that is only I change after I've given 3 doses and the patient
When
has
you think
uh,
about aging, it something comes in your mind, something common thing.
yeah. No, actually I've not till now, touch wood, I haven't like I don't have a
Yeah.
patient who has had any adverse effects or
Right.
a rip in any of my patients yet.
Okay.
But first choice is always Eylea, definitely.
Mm-hmm.
And if I have to consider a second one, that would be Pagenex. I have a couple of patients with Pagenex also who are doing well.
Okay. And how often do you follow treat and extend? Like, how do you go for the loading dose, the main point? Do you follow loading dose and how many
Yes,
injections for your treatment night?
three. Three. I
Three.
give three
Okay.
injections.
So three
After that,
plus.
treat and extend.
So what? Okay. So you follow treat and extend, right?
Yes. It
Okay.
depends. I see the financial background of the patient. If I feel uh, some patients they don't turn up
Mm-hmm.
regularly, so some then they shift to PRN. But otherwise, yes, treat and extend is what I prefer going for. After the initial 3 doses, I try to do that.
Okay. Nice. Anybody who wants to ask any questions?
So, what is? Do you have any experience with the newest Vabysmo? Have
Yeah,
you?
I've been definitely doing Wabismo a lot. So
Okay.
yeah, but then I think yeah, it's definitely a good molecule. There's no doubt about it. But when it comes for the wow experience, I think no doubt aflibercept plays its role. So because whenever we give injections to have a wow experience, it definitely is works with very good in Eylea.
No, and especially their program, the 2+3, the Eylea for You program, that is what actually keeps the patients
Yeah.
going.
Yes. So
That's
our
a big
scenario,
part.
correct. So our scenario is definitely, in India, I mean, I'm sure like everybody has the struggle to continue the injection rather than start the injections, because when we start the injections, it is pretty much we are in a good, level. But then when it comes to continue the injections, our patients are always running, and we are running behind them. So I think in that ways, I feel that treat and extend would always make a very big difference. And especially when we can take even our 50 to 60% of the patients in the category of more than 12 weeks interval,
Yeah,
I think
yeah,
that's something really wonderful to look upon. Yeah.
yeah.
Anyone else? Any questions? Okay, so no more questions for you. I think Dr. Vidhi has joined. Dr. Vidhi, are you there now?
Yeah, am I audible now, sir?
Yeah, you're audible now. Great.
Great, thank you.
So, yeah, so welcome, Dr. Vidhi. So you'll be speaking, I think, about application DME, primary and secondary both, right?
Thank you, Dr. Salman.
Yeah, please go ahead.
Just Am I audible right now?
Yeah, you are audible now.
So, as you are well aware about the pathogenesis of diabetic macular edema, in which chronic hyperglycemia causes an impaired retinal blood flow leading to hypoxia, and then vascular endothelial growth factor and placental induced growth factors mediate vascular permeability, inflammation, breakdown of the blood retinal barrier, and this results in the macular edema as well as neovascularization. So VEGF-A acts through both VEGF receptor 1 and VEGF receptor 2, whereas PIGF binds selectively and with higher affinity to VEGF receptor 1. So even if we completely block VEGF-A, PIGF can continue binding to VEGF receptor 1, especially on activated microglia and inflammatory cells. So this leads to sustained inflammation and contributes to ongoing macular edema. So in DME, we see that both VEGF and PIGF act sort of synergistically, driving this leakage and inflammation. And this is where dual inhibition becomes clinically relevant. So aflibercept, as we know, is a recombinant fusion protein which is designed to bind to VEGF-A, VEGF-B, and most importantly, PIGF. So this was also evaluated in major clinical trials. VISTA and VIVID trials showed the superiority of aflibercept against laser with sustained improvement in visual acuity from 10.7 letters in VIVID and 12.5 letters in VISTA study when compared to laser at the end of 1 year. And protocol T is where it became really interesting. So in DRCA.net protocol T, we compared directly aflibercept, ranibizumab, and bevacizumab. And at 1 year, overall outcomes were comparable. However, and this is the key point here, in patients with baseline visual acuity which was worse than 20/40, aflibercept demonstrated superior visual gains. And if we look at this graph in front of us, it is not just better visual gain, but faster visual gain as well. So if we look, the steepest graph is the one that of aflibercept. So for younger patients or patients who are in a working age group, it's not just better visual acuity gain, but faster visual acuity gain as well, which matters. So based on protocol T, international recommendations and guidelines recommend the use of aflibercept as first line in patients with best corrected visual acuity worse than 20/40. These are a few of my cases. So the first case is that of a 55-year-old business owner who was complaining of blurring of vision in both eyes since 6 months. Is known hypertensive and diabetic, diabetes was uncontrolled on OHS. So this is the fundus photo at presentation where we can see that there is an area of neovascularization near the inferior arcade and multiple cotton wool spots and dot blot hemorrhages, based on which a diagnosis of right eye PDR and left eye NPDR was made. And this was the OCT at presentation in August. The visual acuity in right eye was 6.9 best corrected, and in left eye best corrected was 6.18. So in right eye, we see that there is a small parafoveal intraretinal cyst, and rest of it appears to be more or less fine. Well, in the left eye, there is IRF and SRF and center involving diabetic macular edema. So we advise glycemic control, of course, and left eye Eylea injection, and completed both eye pan-retinal photocoagulation in 3 sittings. This is 1 month post the first Eylea injection in left eye. The right eye vision, to a surprise and dismay, had dropped to 6.18 from 6.9, and there was diabetic macular edema now in the right eye as well, possibly triggered by inflammation from the PRP laser. The left eye, however, we see dramatic resolution of all the intraretinal fluid, almost all of the intraretinal fluid, and the subretinal fluid had also reduced in his height. The patient had improved to 612. So we advise both eye Eylea injection at this visit. The patient then again followed up after 1 month, post 1 Eylea injection in the right eye. All the fluid dramatically resolved, and the left eye SRF had also resolved, and the patient had improved to 6.6 partial in both the eyes. The patient was very much satisfied at this point, so it was a bit of a difficulty in convincing him to complete his loading doses. However, we were able to convince him for a third injection of Eylea in the left eye. The right eye, unfortunately, he was unwilling to continue any further injections. So after third injection in the left eye, the visual acuity was maintained at 6/6 partial in both the eyes, and there is complete resolution of diabetic macular edema. The patient last followed up with me 2 weeks back. He continues to maintain this 6/6 partial vision, and he's happy and satisfied. So we see that there was a faster resolution of diabetic macular edema and sustained resolution with injections of Eylea in this patient. Uh, this is the second case, which is a 67-year-old housewife who was complaining of blurring of vision and seeing a black small spot in her right eye since 1 year. She was hypertensive but had stopped medications 3 years back and again diabetic on OHAs. She had undergone both eye cataract surgery elsewhere and in 2022 had been diagnosed with both eye mild NPDR and right eye diabetic macular edema and given one injection of Avastin. However, as Dr. Saurabh was discussing right now, she, as is the difficulty with a lot of these patients, she did not follow up with the primary treating surgeon. This is the fundus photo at presentation. We can see that there is what appears to be a few dot blot hemorrhages and some hard exudates near the fovea in the right eye as well in the left eye, and there is disc pallor. On closer examination, we found one singular NVE in the left eye. So we went ahead and we also did FFA for this patient just to rule out PDR in the right eye. She did not have PDR in the right eye, but we did do PRP for both the eyes. This is the OCT at presentation. Remember that the right eye had already received an Avastin around 2-3 years ago. And we could see that there is some early drill which is setting in temporal to the fovea, and there is a large intraretinal cyst with loss of outer retinal loss of outer retinal bands. There is ELM and EZ discontinuity as well, and then we also see those hard exudates temporally and hyperreflective foci. This is the OCT of the left eye at presentation, where we again see intraretinal cysts and then something called as ICHRM, which has been described in literature as a poor prognostic biomarker for diabetic macular edema. And although the ELM was continuous, again there were focal EZ disruptions in this eye as well. So the patient was diagnosed with left eye PDR with hypertensive retinopathy, right eye severe NPDR with hypertensive retinopathy, and both eyes center involving diabetic macular edema. A physician referral revealed elevated blood pressures. The patient was restarted on antihypertensives and was advised both eye ranibizumab injections along with both eye PRP. So this is after the first injection of ranibizumab. The visual acuity improved from 20/100 to 20/80 partial. We see that there is reduction in the size of intraretinal cyst, and the drill temporally becomes much more apparent now. Just as a reminder, the inset shows what the OCT previously looked like. This is the OCT of the left eye after the first injection of razumab. The visual acuity remained stable, and there was no apparent change in the size or the number of the intraretinal cysts. So we advised repeat injections of razumab for both the eyes again, Accentrix for both the eyes again. The patient improved further in the right eye from 20/80 to 20/60 partial. There was complete resolution of the intraretinal cysts, and the ELM and the EZ disruptions became more apparent along with the drill temporally. In the left eye, there was reduction in the size as well as the number of the intraretinal cysts compared to the last visit, and the visual acuity also improved to 20/30 partial. The patient was then advised a left eye third injection of Accentrix. However, to our dismay, when the follow-up visit of the third injection, we noted that the right eye edema had recurred, and there was a drop in vision from 20/60 to 20/80. And we could identify drill nasally as well now. And in the left eye, there was again increase in edema, increase in the central macular thickness, increase in the number and the size of the intraretinal cysts as well. We postulated that this might be because of so-called tachyphylaxis to molecules of ranibizumab and bevacizumab, which has been described in literature. So we advised Eylea in both the eyes, and even after the first injection of Eylea, we see that the DME improved drastically, but the vision dropped further, the cause of which was thought to be macular ischemia. In the left eye, however, the patient improved to 20/40, and again, with just one injection of Dialia, there was dramatic improvement in the diabetic macular edema. The patient was advised systemic control and asked to review at 1 month. As much as we would have loved to continue and give 3 loading doses of Eylea, the patient was unwilling to utilize their free injections for this for the same. So the patient then followed up 2 months later instead of 1 month when they noticed a drop in their vision. Again, we could see that there was recurrence of edema and drop in vision in both the eyes. We advised both eye second Eylea injection, and then the patient again showed improvement in diabetic macular edema with improvement in vision. So this patient is currently on follow-up, and we were able to offer at least longer interval between the injections for the patient with Eylea. So we were able to keep a gap of 2 months, and we could see dramatic anatomic response after each injection of Eylea, which was not seen with the previous both of the types of injections the patient had received. Thank you so much for your kind attention.
Thank you, Dr. Bajpayee. I think the cases were pretty good and the presentation was very descriptive. So, yeah, okay. So, diabetic, I mean, how do you go with your naive patients? What do you prefer, like, as a first line and a second line, or when do you switch your patients?
Thank you for the question, sir. So, I follow protocol. I try to follow protocol T. Let me put it this way. Where
Okay.
I'm practicing right now, the economical conditions may not allow it. But yeah, if the patient appears to be affording, or they have insurance, or they understand the mathematics of the previously allowed, patient support program, that in the end each injection costs less if we look at the long term. If you're giving the lesser number of injections and then a couple of injections in between are free. So I try to start with Eylea. If not, then of course biosimilars or Avastin is also available in a place. Then that goes according to their economic background.
So,
For
yeah.
switching, I like to give at least 3 injections of each kind at 1 month interval. I'm very strict about it. Patients have to follow up at 1 month with me. I have to see how they're responding, and the sugars have to be under control. And after that, I'll consider switching maybe. But if I am seeing even minimal inclusion improvements in the OCT, and by minimal improvements I mean in not looking at just the OCT B scan, but also at the heat map. So the area of the DME also matters to me as well, not just the central macular thickness. If I see that there is a reduction in the area, I count that as a response, and I'd like to continue the same injection before switching.
Okay. Okay. So you mentioned protocol T as your this thing USP. So what I was asking one more question that do you follow the vision criteria in protocol T as per what it indicates whether we should give an Eylea or some other drug probably?
I try to, yes, sir.
Yeah.
Uh,
Yeah, sure. Himanshu, you want to say something?
Yes, sir. Sir, actually, I just wanted to request all of the doctors to please switch on the cameras if possible, just for the documentation purpose, sir.
Yeah, sure.
Yes, sir. Thank you.
Okay. So all of us looking good, Himanshu? Can you?
Yes, sir.
Okay.
Good to see you, sir, after a long time.
Yeah, I know. Thank you. So, okay. So, yeah. So I was asking, yeah, the vision. I mean, Dr. Vidhi, how do you treat with the 6669 vision, and you have a center involving DME? How do you
I
convince
don't.
it? You don't?
I don't treat, sir. I will tell them that there is a possibility that this may resolve with just good systemic control, and if suppose they have severe NPDR as well, depending upon I can assess on their economic background and the likelihood of them being able to follow up with me. I'll probably
Mhm.
go ahead and do a PRP just to reduce that CNP area, peripheral CNP area. But yeah, I will not treat at 6669, sir. If it's center involving or not center involving, I will not treat. I will like to keep them on 1 month, 6 weekly follow-up, but more often than not, it ends up me telling them that, come when you feel that the vision is dropping, if
Yeah,
you're
I think
able to.
I think there is 2 points here. Like I would say that one thing is when the patient comes to you at 6669 complaining of vision, vision complaints, and you have diabetic macular edema, center involving. One thing is patient is not complaining. Patient just come for a routine checkup. a lot of time you've handled such patients. We are coming at 6/6 vision, and they expect the vision, to be little bad because of the power refractive error. And when they check, they are pretty much comfortable. So any differences on that point? If your patient is complaining and you can see there is a DME, you can see there is the foveal contour altered. It is definitely you have cystic spaces. Any
So,
change in your approach?
um, so I tend to follow what my fellowship had taught me. In protocol,
Mhm.
they did compare for 6/9 vision up till 6/9 vision with observation, and I have had cases, documented cases. There are people who are very young, type 1 diabetics, who do feel because they are young and their work requires them to work on laptops, and they are very sensitive to the loss of vision as well. But if I have stressed upon the systemic control and kept them on regular follow-up, I've seen almost all of my DMEs resolve. If they're increasing and the vision is dropping, yes, then ahead. But because if you start on that wagon, sir, where do you get off? Hello. If I
Mhm.
start injecting at 6/9, say the patient becomes 6/6 at, say, after one injection, but then should I go ahead and complete my other two injections just for the sake of it? So I need to have an endpoint in mind, that where should I
Mm.
stop injecting?
Okay, okay. And anyone with questions? Anybody who wants to ask any questions?
I have a question.
Yeah.
In say what the kind of patients you're talking about, like the vision is 6669, the
Mm-hmm.
patients are coming with, say, some kind of complaint of blurring. So
Yeah.
how, like, for how long do you leave it? Like, so I have some patients who come, say, after 3 months, and they will still complain that okay, the vision loss is there, we have good diabetic control, and on the OCT it is similar. So like,
Mhm.
till when do you wait to start injecting? Because the patient is still complaining that no, my vision is still not clear. Now my glycemic control is very good. Well, most patients, they don't really follow it, and when you see the reports, then you know that it's not that great control wise. But like, so what is the end point? Like, when do you just feel that no, now I have to inject in such patients when you're not preferring to inject in the first go, even though you see like there is some kind of foveal contour is disturbed, it's not maintained, and if there's like small IRF spaces.
Yeah, so Dr. Aditi, I would probably treat it a little different way. That's why I asked Dr. Aditi also. Like, I would say that my patients come with 6/6 and stent involving DME, and I can see they're complaining of visual complaints. I would not wait. I would treat them because nowadays we have a very good, we have a good range of our anti-VEGF injections. We have been seeing that we have a very good safety efficacy data. I personally don't think we should wait because you're right. I mean, a lot of times they'll complain of similar complaints even in the next visit, and all the more they are like they become little hopeless in that ways. But yes, it's not always true. In a way, yes. But if my patients don't complain of vision complaints, and I can see the DME thing, then probably I explain them in my own language that okay, yeah, you have something which is going to come up soon or later, and we might need injections. So that is something different we can always share with our patients, and you can keep them on a short follow up. So this is how I follow. Dr. Vidhi, you want to put something on that?
So personally, a long way, I think, does, as you said, Dr. Saurabh, that it does go in how much we counsel. So my counseling usually goes along the lines of, it took you a long time to get here, right? You had delayed blood sugars for a pretty long time for you to reach to this point where you need treatment now. So
Mm.
let us, it will take the equal amount of time for it to go away. So that's how I start counseling. So I think counseling needs a little bit, counseling them to have a little bit of patience. But yeah, it's an interesting question, Dr. Aditi, and I'm fortunate enough to have never faced that situation in my practice as of now, where if the patient's glycemic control has improved and the diabetic macular edema has not improved along with it. But I guess, yeah, I would wait for a couple of months at least. Wait for the HbA1c to go down a little. I know that takes a little bit of time, but still, diabetic control is not achieved overnight, unlike what the patients like to think. So,
Yeah,
yeah.
like, I mean, I would definitely the glycemic control stands very, very important. There's no doubt about it. Along with that, I've been even other systemic factors like hypertension, cholesterol, and all would be important too. But yeah, I mean, yeah, there might be some different approaches which probably you'll deal with such kind of patients. And I think there's always a debate for these patients. There's no something, nothing new. That 6/6 vision, and I mean, whether you treat it or you don't treat it. I think there's just one other question to it, that whether patient is complaining or whether patients are not complaining. So I would answer on that point. So if you have DME with 6/6, yes, if patients are complaining, I would say I would treat it. If patients are not complaining, then I would probably wait and keep them on a close watch and then decide accordingly. Dr. Aditi, you want to put your approach? What do you think you would do?
No, sir, I also follow the same approach. If the patient I feel is so most of the patients who are well educated or who are coming from like an okay kind of financial background, I encourage them to get an injection. I in such patients sometimes I don't follow the like the 3 monthly thing. I give them one injection, and if then I keep a good regular follow up, say 6 weekly follow up. And in a lot of my patients, if the glycemic control is good, if they're dedicated enough to the disease, then I don't need to give more injections.
Mhm.
So initially, if I feel the patient has some complaint, then I encourage them to get injections. Then if the patient, sometimes patient come with 6/9, 6/12 vision also, and they're not complaining of vision loss, and I see minimal vision, like minimal inflammation, DME. So, and if it is not, especially if it is not center involving, then I give them some time. I ask them to try to control their blood sugars and come back. And yeah. But like if it is beyond 6/9 parts or say 6/12, then I just give them the injection.
Okay, so I think another question very important here would be, I think, Himanshu, are we getting late by any chance?
No, sir, we are right on time.
Okay. So another thing which I would like to highlight here is like about how about like treat and extend now. So Dr. Aditi and Dr. Viti, I mean both of you, or maybe somebody else who wants to add in into anything. So treat and extend is something very unique, and we are going forward with an evolution as we just discussed. Something most important, that are we able to achieve that thing, treat and extend? Because I feel it will be much better and more easier because of our Indian scenario where we are not covered under insurances. We have a lot of constraints, we have limitations. Wherein treat and extend, if we can take our patients to 16 weekly injections or even more than 12 weekly, it's a very good, kind of a win-win situation. So, any highlight, anything, any comments on that, Dr. Aditi?
I think Dr. Aditi has.
Okay, Dr. Aditi, you want to put in something, please?
Uh, I think I've not been so lucky as been to be able to convince my patients to go on the treat and extend regimen. Most of the time, I try giving up. I think I have only a couple of patients, not on Eylea, who have been able to take to treat and extend. Uh, Also, I have noted with CNVMs, I mean, there are studies now as well, Dr. Saurabh. I'm sure you're aware that you can sort of stop treatment also after some time. So I think that's great if reaching a 16-week interval and then we are able to stop the treatment as well completely with minimal amount of recurrence, that would be great. But for me, most of the cases end up with convincing patients to get 3 loading doses, because especially in CNVM cases, the visual acuity gain may not be as much. We may be seeing a lot of response on the OCT, but vision acuity wise, the patient is generally 90% of the times pretty unsatisfied, unless if they were counting fingers and they become 660, 636, or 624. In most of the cases, especially where I practice, because of the economic background, I am on PR. And if I'm able to
Yeah.
convince them to even have 3 loading doses, I think that's a win for me. I count it as win.
Okay, okay. Dr. Aditi, are you there?
Yes, sir.
You want to put
Uh,
something, treat and extend mainly?
yeah, like I have a few patients, I would say more than a few right now, but it is catching up. Uh, so
Mhm.
as you know, as you go along, as you spend more time I have been here for almost 2 years now.
Okay.
So like it is a very gradual thing because the patient's confidence doesn't come as soon
Mhm.
as you would like. So I try to convince the patients, and I would say my ratio would be say 30 to 70. So 70% of the patients still the PRN regimen is being continued. But
Mhm.
yes, I have said around the patient, the 30% patients I have been able to convince, and I try, and I feel that it will catch up, but it will
Yeah, I
take
think, yeah,
time.
it takes time. Yeah, yeah. So, I mean, definitely we have the recent trials which have shown a beautiful results on treat and extend. And just you were discussing only the two trials, and the average number of injections have also come down almost to 10. So that's something which is very encouraging, though, I would say. And again, like, moreover, if you see DME also, I mean, that's all again one other thing where we need injections on a regular basis. But I would not never say that DME. I would say that, yeah, I mean, there might be somewhere we can probably hold on injections, because patients are a lot of times uncontrolled, and patients are not very much willing to keep getting injections. So there probably we might have to change our protocols and change our approach, where we have to. I also believe it is going to take a little more time. Manju, you want to add something as per your the
Uh,
trials in your, yeah.
Yes, sir. So, regarding the treatment patterns across the India, whatever KOLs I have interacted with. In
Hmm.
fact, day before yesterday, I was in a conference in Amritsar where Dr. Dinesh Talwar was speaking. So,
Okay.
like Dr. Aditi and Dr. Vidhi also mentioned that during counseling, if AMD patient is there, then he always uses this one line that तुमको इंजेक्शन तब तक लेना है जब तक या तो मैं न मर जाऊं या तो तुम न मर जाओ. So this
Very
is
good.
his line for
Very good.
AMD
Yeah.
patients.
Yeah. Yeah. Yeah.
And for DME, he says that initially he will go intensive therapy, 2 or 3 injections. It's not fixed number of injections for him, whether it is 2 injections, 3 injections, or 5 injections, whatever is needed to control the fluid. Post that, he will go on PRN. And like you said rightly, that in DME patient, it takes it a little bit easier as compared to AMD, because in AMD, vision lost cannot be recovered. But in DME, that is not the case. So
Correct.
that's his take, and most of the other senior KOLs also believe in this theory regarding both AMD as well as DME, sir.
So DME, these DME patients have more systemic, other
Yes,
systemic
sir.
issues also, which probably have more concerns for them. And that is the reason that if you don't be with them on a right time, I think they might just skip off and change doctors.
That is. There
And
is
but
a, yes,
yeah,
sir.
but however, your AMD patients are on a very different note altogether. They may not be diabetic, and they may not have kind of they are very much pro into this कि at least three, okay, we'll put three. तो उसके
Yes.
बाद तो खत्म हो जाएगा ना, तो उसके बाद खत्म होने का आंसर we have a little bit, we can probably explain them later also. But for diabetic, it is little difficult to, and no doubt counseling makes a very big difference, how you counsel your
For diabetics,
patients.
I think the systemic issues also come into play. A lot of the times they
Yes.
may fall sick in
Yes.
between, they go on dialysis. A range of nowadays with a lot of nephrologists sort of counseling against a lot of the anti-VEGF injections, that has also started factoring in the
Yes, ma'am. So
counseling for.
exactly the same discussion was happening again day before yesterday. So Dr. Talwar said that if there is a patient who is comorbid, जिसको nephro का भी issue है, so he does not start with his injection unless the patient's nephro okays it. Because
Hmm.
his take is like कि बाद में कुछ होता है, then nephro puts everything on us that you used anti-VEGFs. That's why the nephro condition deteriorated. सो अगर ऐसा कोई पेशेंट आता है तो वो उनको नेफ्रो के पास भेजते हैं बाकी जिससे ट्रीटमेंट व्हेन दे ओके देन ओनली ही स्टार्ट्स विद एंटी VEGF इंजेक्शंस.
I think as far as clearance is concerned, so I have interacted with Dr. Dinesh Talwar a lot.
Yes,
I am a
yes, sir.
visiting consultant at Center for Sight also.
Yes, sir.
So I'm still, I think yes, he very rightly said what we follow even over there and what we follow in our practices. क्लियरेंस लेना तो बहुत जरूरी है इनसे,
Yes, sir.
चाहे वो नेफ्रो हो, चाहे वो कार्डियो हो. Even I had one episode wherein patient had some kind of an angina, and I had given one anti-VEGF, and the patient came to me and asking me that sir आपने कौन सा इंजेक्शन दिया है, क्योंकि मेरे जो हार्ट वाले डॉक्टर हैं वो कहते हैं हो सकता है इससे ना हो गया हो. So for me, it was a little difficult to answer that particular movement. So even I prefer taking a cardiac clearance if the patient already had a PTC or a CABG.
Yes.
That's another thing. Yeah, I mean, no doubts. We always, even Center for Side, me, Dr. Lalit Verma, Dr. Dinesh Talwar, we prefer taking, and clearance in our patients like that. How about you, Dr. Aditi? How about you, Dr. Vidhi?
Yeah, yeah, same here, sir. I would like to take clearance just for the fact that I have also had patients who have come back and told the nephrologist is saying that the nephropathy got worse because of the injection that you're taking.
Yeah.
Um, and
Yeah,
as
it's
often is
definitely.
when I first heard this, yeah, go ahead, Dr. Aditi.
No, no, it's fine. You continue.
Go. I think Dr. Vidhi
No,
finished.
what I was saying is that, whenever we are confronted with, yeah.
Go ahead, Dr. Vidhi. Are you there?
Is it me or Dr. Aditi? I'm sorry. The names are quite similar. I'm so sorry.
Whoever is there, I don't mind, yeah, anybody.
No, no, you can continue. You finish, then I'll
No, as
speak.
I was saying, I think better to take a nephrologist's opinion. Although I think if any of us goes, uh, I have been through the literature quite a bit. I've combed through it, trying to find out if this actually stands true or if this is some just, where sort of an agenda. But really, I've not found anything, any concrete evidence which points towards anti-VEGF leading to a worsening of nephropathy. It's more of a theory as of now. But yes, if it's something which is being propagated to patients just for their sort of peace of mind, if we have to, we should definitely take cardiologist and nephrologist clearances.
Yep. Dr. Aditi, you want to say?
I also feel like, in today's time and age, we need to be safe ourselves. So for me, it
Yeah.
is also that is also a big point that like the patient shouldn't come later on, telling me that there was some problem with my treatment. So I tell them that first you get your clearances and then we'll just go ahead with the treatment, because at the end of the day, I tell them that yes, your nephropathy, if it gets worse, then you won't be coming to me at all for your eye. That will be your major concern. So
Mhm.
let's get that sorted first and then we'll treat this.
Yeah, okay. I think, yeah, I mean, that stands common for everybody of us, every one of us. Okay. Any questions from the audience again? Anybody who wants to ask any questions can speak up or probably put a message on your box.
If I may, Dr. So I think I missed a part of the discussion. I was keen to ask Dr. Aditi if uh, for the large PED patient that she injected, was that discussed, or is this, would I be repeat the discussion again? Uh, this
I
large PED in another patient that she showed,
Mhm.
respond to the IUI injection?
actually, I'm still waiting. Patient, it's been only 2 weeks since I injected that
Have
patient.
you given before as well for these large PEDs who don't,
Yes,
matlab,
yes.
and there is
I
no
have.
anti-CNV, they have
No,
responded?
yes, they have responded, and some patients have responded quite well. In fact, I was also surprised.
Okay.
This
So
patient
Dr.
hasn't,
Saul,
it's been only 2 or 3 weeks yet, so I don't know, but this patient will still come. But yeah, so I have a few cases where the patients have responded well.
Okay. But only another thing which probably I just slipped off. Like you were treating the other eye wherein there was just a PED. Am I right?
Yeah, but initially when the patient first came, the vision was 660, and
Okay.
there was a little bit of macular hemorrhage also. So
Okay.
that is why I gave the first injection.
No, but then the patient. I think this was the same patient.
Last case, right?
Yeah. I mean, you said there was a PED in the other eye probably, and there was no signs per se. Like there was no.
Yeah, the vision was 6.6 that time in the other eye, and they were
Okay.
very shallow PEDs.
Okay. And then later on, you mean to say just vision came down.
Vision at presentation, the right eye was 6.6.
Okay.
OCT picture was very similar in both the eyes, but the left eye vision was 660,
Mm-hmm.
and there was a macular hemorrhage.
There
So
was a
that's why I
macula.
went ahead with the left eye. The OCT was not remarkable at all. Like if I had just looked at the OCT, probably I wouldn't have, gone
Yeah,
ahead with the patient. But the patient was complaining of diminution of vision, and I could see like a macular hemorrhage, so I went ahead with the
yeah,
injection.
yeah. So you could see the macular hemorrhage. No, that's
Yeah,
what.
yeah.
Yeah.
So
So do
Dr.
you have?
Saurabh, do you also
Yeah.
inject for huge if you see a huge PED but not a sign of CNVM per se, like there is no fluid, do you also inject, or is what is
Tall
your approach to
PEDs, yeah, tall PEDs, I will never mind to inject this. Yeah, they are chances of rip. We have to, again, the same thing, we have to counsel the patient nicely for those things, those risks attached to it. But yes, I would seek for some kind of a clinical, signs. I would not inject only for a tall PED, wherein we have usually get vision of 6669. Yes, if I have an SRF in my patients, if I have some kind of an exudation, if I have some kind of a macular heme, which probably I can see clearly, and I can probably think about it. But if I have a facility of an FFA and angio, as I said initially, ICG and FFA I can do, I would probably go that first and then plan my injection. But in
and,
case
and
of scenarios where I cannot do, I would say that I would seek for some clinical signs wherein I would do my injection, like, give my injection, not only for the
if you
PAD.
suspect a
Sorry?
CNVM, then only you will inject. So matlab you're essentially saying that if you suspect a CNVM, then that's the only time you'll inject, but not
Yes.
just for a PED. But
No,
once in
not
a while we do.
not just for a tall solitary
Yeah.
PED lying over there and doing nothing. I would not inject. I would wait for it to, probably keep a close watch, even if the other eye is involved. I have a lot of patients, but usually they keep silent. But yes, as she said, no, Dr. Aditi said she could see the, there was a macular heme involved and the
Yes, yes.
patient was complaining. Then in that case, yes, you can. I would say we should, in fact, because when there is already a sign present, then I think we should go ahead and do it.
And then, once in a while we do get these young patients who have just a PED, say a pachychoroid and then a PED, and there is no other sign.
Mhm.
And because they are young, probably sort of a little more of a type A personality as well. So they'll
Mhm.
be complaining of that metamorphopsia, and they have been to several doctors. They'll show you all of these OCTs as well. Then does your approach change in those patients then maybe?
No, nothing at all. No injections when you don't have signs. I will not.
Okay. Okay.
Because PEDs you will find a lot of many much often. I mean, max, if you have something, as I said, SRF should be there or a heme should be there or some clinical signs which probably leads to you give injection. Because these young patients, I agree they complain sometime of metamorphopsia, but I think we need to counsel them nicely to just have a close watch.
So if you have a notched PED, then
Notch PD again, I says, I would look for clinical signs. I would look for other signs too, because there'll be a lot of time you'll have a small notch. But as far as see notch PD, if you are not able to do an ICG and you're not able to rule out
yeah, yeah,
ECV, then why are we even injecting, right?
yeah,
When
yeah.
you are waiting for, when you're treating the patients in limitation, then I think just wait. I will advise just wait for some time, just keep a close watch. I think nothing happens most of the times. Yes, if they land up having some issues in terms of SRF or exudation, then probably I would treat them.
No, but say if the vision has drops to 6/9,
There should be
and
some sign, no? I think, what do you say?
still you'll still prefer
Yeah,
waiting.
no, but if there should be some sign if the vision is dropped. As you said, no, in your own case, there was a macular heme, which I
Yeah,
can
yeah, there
get.
was. Yeah.
Yeah,
But I
So,
have a few young patients like you were talking about where
uh,
the vision is, 6/9. It's not 6/6 and they complain of metamorphopsia. But there's no IRF, there's no SRF. I don't see any other clinical sign. But
mhm.
it's hard to counsel because I show them the OCT and I tell them, but it's like, for how long do I have to wait?
Yeah, so
They,
I mean, this particular thing, no, so we are talking about PD, though. I'm just taking you in a different,
yeah,
different zone now. So there are a lot of patients in myopic CNVM per se, where you may not find, very clinical signs, appealing, right? Then I would say then you have a very good definitive leak on FFA. You might have a pretty much good leak over there. SRF may or may not be there. You
mhm.
may have, those kind of signs wherein, yes, I go ahead because I have some evidence that there is a leak there. So then I do inject, but if there is nothing, then probably no. I would wait, even if they say that they have a vision, drop, but just a solitary PED with nothing like that, I think yes, we need to explain. I would go that.
Okay, okay. Thank you.
Yeah. So anything else? I think we had a very good session and a good discussion. Thank you, speakers. Thank you, Dr. Diti. Thank you, Dr. Vidhi.
Thank you, Dr. Sir.
And
Thank you.
Thank you, sir.
thank you so much. And Himanshu, you want to add something as your address?
No, sir. Firstly, again, I'd like to thank both the speakers and obviously to you for moderating the session so well. The discussion was quite elaborate and enlightening, sir.
Yeah,
Again,
thank you. Thank
yeah.
you.
Thank you all the participants and have a good night.
Yeah. Good
Thank-
night.
Thank you. Thank you so much.
Yes.
Thank you, sir. Thank you, sir.
Thank you.